Good morning, everybody. At the outset, I would like to thank the scientific committee for giving me this opportunity. I would be talking about disc evaluation and photography. As we all are aware, a change in the appearance of the optic nerve can be the first finding in a glaucoma patient, and glaucoma is a progressive optic neuropathy, and hence examination and documentation of optic nerve is a cornerstone of clinical evaluation of glaucoma patient or suspect. Pointer, please. A proper optic nerve head examination can detect glaucomatous damage prior to visual field analysis, and hence meticulous optic nerve evaluation is of fundamental importance in the management of glaucoma. There are different methods of optic disc evaluation. We can do it by direct ophthalmoscopy, indirect ophthalmoscopy, and slit lamp biomicroscopy. Slit lamp biomicroscopy with handheld lenses is the best method of optic nerve examination since it provides good stereopsis and magnification. Now, what are the 5 R's during optic disc evaluation? Optic disc size and shape, that is scleral ring, NRR evaluation, neuroretinal rim evaluation, retinal and optic disc hemorrhages, RNFL defect, and region of peripapillary atrophy. Let us see the first R, optic disc size and shape. The normal disc vertical diameter is 1.4 to 2 millimeters. Less than that is small disc, more than 2 millimeters is a large disc. Normal shape of the optic disc is slightly vertically oval, and the longest diameter is 9% longer than the horizontal. This is the small disc we can see. This is the large disc, the red-free photograph and the colored photograph. How to measure the disc size? On slit lamp examination, adjust the height of the slit beam to correspond with the margins of the disc. Note the reading from the graticule. Use the appropriate magnification factor depending on the lens used. If you are examining by 60 diopter lens, magnification factor of 1, 78, 1.1, for 90 diopter lens, 1.3. By direct ophthalmoscopy, we can also measure the disc size. The 5-degree aperture on the direct Welschelen ophthalmoscope is just slightly smaller than an average size optic nerve head. So this is the small video which is showing how to measure the disc size. Here actually the graticule is there. Here we note the reading, and then according to the lens type used, we use the magnification factor. Here a small thin slit beam is created, and you have to align it with the vertical dimension of the disc. Then NRR evaluation. Neuroretinal rim is the area between disc margin and cup margin. Neuroretinal rim is the area of optic disc which is occupied by axons. In normal optic disc, neuroretinal rim follows Isn't rule. Inferior rim is the thickest, then superior, then nasal, and then temporal. Thickness, color, and contour of neuroretinal rim should be compared in each of the 4 quadrants. The glaucomatous NRR damage may be diffuse, focal, or it could be a combination of the two. Nowadays, rim to disc ratio is considered more important than cup to disc ratio. Rim to disc ratio of less than 0.1 in any area is considered pathological. If area of pallor is more than area of cupping, then consider causes other than glaucoma. So here you can see the pallor is more than cupping. In glaucomatous NRR damage, you could get the notch. Here there is actually the superonasal notch, and here we are seeing the inferotemporal notch. Then the third R is retinal and optic disc hemorrhages. These are Drans hemorrhages, usually splinter or flame-shaped on the disc surface, usually in superotemporal or inferotemporal rim. They are more commonly seen in NTG, normal tension glaucoma. They are transient and usually last for 2 to 4 months. Corresponding visual field defects may appear weeks to years later. And the other causes of these splinter hemorrhages could be PVD, trauma, hypertension, and use of anticoagulants. Then the fourth R is RNFL defect. RNFL actually corresponds to the nerve fibers passing from the photoreceptors over the retina as they come towards the optic disc, and these are seen as silvery striations. So here you can see these silvery striations. In the red-free photographs also we can see the RNFL. In affected areas, normal silvery striations are lost, fundus appears darker and deeper red, slit defects may be physiological, wedge-shaped defects extending up to disc margin, they are typical of glaucoma. In later stages of glaucoma, there could be diffuse atrophy of RNFL, which is found. So here we can see the RNFL defect, normal RNFL in the upper part. In the inferotemporal area, we are not able to see the RNFL. Here the media is hazy because of media opacity, and there is diffuse loss of RNFL. The fifth R is region of peripapillary atrophy. Two distinct zones of atrophy, alpha and beta, surround the optic disc. Peripheral alpha zone shows irregular hypo or hyperpigmented zone associated with chorioretinal thinning, and the central beta zone represents loss of RPE and choriocapillaries, leaving intact choroidal vasculature. Beta zone atrophy is seen more in glaucomatous eyes, and it increases with progress of disease. So here we are getting these alpha and beta zones. The RNFL contains retinal ganglion cell axons covered by astrocytes and bundled by processes of Muller cells. In juvenile subjects, the evaluation of RNFL is more difficult than in adults because the reflectivity of internal limiting membrane is considerably higher in children. These RNFL bundles are most visible in temporal inferior sector, followed by temporal superior area, then nasal superior, followed by nasal inferior area. So you can see these highly reflective RNFL, these very shiny RNFL in young patients. These are least visible in superior, inferior, temporal horizontal and nasal horizontal regions. Visibility of RNFL decreases with age, and RNFL loss can occur as a diffuse loss or localized loss. Localized RNFL defects occur more often in eyes with NTG than in eyes with age-related atrophic type of open-angle glaucoma, highly myopic type of open-angle glaucoma, or juvenile onset type of primary open-angle glaucoma. Always look for symmetry of the optic disc, and the asymmetry between the two optic nerves suggests possible presence of glaucoma. Then there are few terminologies. We can have the acquired pit of the optic nerve here. We can have the bevanating sign. We can have the bearing of blood vessels. The bridging is when disc vessels hang over an area of lost neural tissue. There could be saucerization or bean pot cupping. Myopic disc actually confuses us many a time. There is oblique insertion of optic nerve in case of myopic disc. There is distortion of temporal neural rim, suggesting pathologic thinning. Disc is large, cup is shallower than usual cup, and there is temporal peripapillary crescent. So here it is the typical myopic disc we are seeing. What is the differential diagnosis of glaucomatous disc? Optic pit could be there, isolated optic disc coloboma, ocular ischemic syndrome, and tilted disc. Always draw a disc. The purpose is to monitor glaucomatous changes. First draw the outline of the disc, then draw the cup, and then demonstrate the localized thinning, generalized thinning, or NRR notch or disc hemorrhage. Then there is something known as disc damage likelihood scale. It was brought forth by Dr. George Spith, and it has got 10 different stages. It can monitor disease progression better. Any disc graded stage 5 or higher is unhealthy, and it is actually based on the size of disc, width of NRR, and circumferential extent of rim absence. So this is the disc damage likelihood scale. Pay attention to disc size, pay attention to rim contour, pay attention to rim color, and look for corroborative findings. There could be two types of disc photography, two-dimensional and three-dimensional. Stereo photos are best suited for evaluation and documentation as baseline for future comparisons to determine progression. They consist of image pairs obtained simultaneously or sequentially with a spatial shift that provides retinal image disparity. And retinal image disparity actually gives the assessment of cup depth, excavation, and rim contour. We can take the stereo photos with standard fundus camera or simultaneous stereo photography, which requires a special camera with beam splitting prism. The photos need to be centered on the optic disc. Red-free photos should also be taken to view the nerve fiber layer defects. You have to view the stereo photos using a stereo viewer or use of 3D monitor and polarized glasses. There are some advantages and disadvantages of disc photography. Advantage being we can compare it even years later, but the disadvantage, it remains subjective. To conclude, stability of a patient's glaucoma is often best determined by evaluating the optic disc, and studies that used optic disc and RNFL photography have shown that an increase in cup area or thinning of NRR, emergence of focal rim notch or splinter rim hemorrhage at the disc margin, and thinning of RNFL may all precede glaucomatous visual field changes as tested on achromatic perimetry. Hence, good disc evaluation is a very important part